Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome everybody again to another episode of our show, bringing you another really fascinating guest today, helping to create a better tomorrow on some really unique fronts. Today we have the honor of being joined by Professor Dr. Christine Stabell Benn, who is physician, professor of global health at the University of Southern Denmark, and a vaccine researcher with almost 3 decades of experience in the field, where the focus of her research has been on non-specific vaccine effects, those defined as other effects, which can be both positive or negative, that vaccines may have on our immune system and overall health beyond their very specific ability to protect against specific infectious diseases. Professor Stabell Benn has her medical degree, her Doctor of Medical Science, and her PhD, all from University of Copenhagen, has been responsible for planning, executing, and publishing epidemiological and immunological studies of health interventions internationally, as well as supervising a number of pre- and postgraduate students at the same time. She started working as a medical student in 1993 at the Bandim Health Project, a population-based health research project in one of the world's poorest countries, Guinea-Bissau, focused on developing a health and demographic surveillance system of over 100,000 individuals. She spent postdoc time at the Danish National Hospital, Department of Infectious Diseases, and at Stanford University. And in 2012, she was selected by the Danish National Research Foundation to establish and lead a center of excellence for the Research Center of Vitamins and Vaccines, and has published some really fascinating work at the intersection of these 2 domains. We are really lucky to have her with us today. Professor Dr. Christine Stabell Benn, thank you so much for taking the time to come on the show.
Thank you for inviting me and for the nice introduction.
It's really great having you. Before we get into some of these themes, I would love to, as we typically do, just hand you the floor for a few minutes to talk a little bit more about your background. If you could just introduce yourself from everything from where you grew up, how you got interested in both medicine and epidemiology. I think that would be a great way to start off what we're going to be getting into.
Well, okay, thank you. I didn't prepare for that, but I can tell you just briefly that as a medical student, when I started, I thought, like all medical students, I guess, that I wanted to become a physician, work with patients. But at some stage, I also realized that I would like to work with global health and to improve or try to combat the inequality in health globally. And I developed a research project together with another student to look into to do a project basically which was about global health, and got interested that way in doing research as a manner of not as working as a medical doctor, but not directly with patients, but more doing research in terms of trying to identify new treatments or prophylactic interventions or other things that could kind of more at the population level make an impact. So with that as a background, I started studying the literature to define a research topic for myself. And I stumbled over an abstract which was written actually by Tom Frieden, who later became the director of CDC, written while he was a pediatrician working in New York, and he saw that if they gave vitamin A to children who had measles, the children who got vitamin A compared with those who got placebo, they developed more antibodies towards measles during their infection. And he speculated by the end of the abstract in the scientific paper that he wrote that maybe vitamin A could be used to enhance the antibody response also to measles vaccine. And I started looking into the literature. I thought that was an exciting idea. I wondered if anybody had studied it before. And I found out that it was actually already policy in low-income countries to give vitamin A with measles vaccine, but this was done merely to protect against vitamin A deficiency. Mm-hmm. So nobody had actually ever investigated whether combining these two interventions, vitamin A on one hand and measles vaccine, would alter the response to measles vaccine. Everybody thought that vitamin A was about preventing vitamin A deficiency and measles vaccine was about preventing measles infection, but the interactions hadn't been studied. So inspired by Tom Frieden, I developed a research project to look into whether vitamin A supplementation given with measles vaccine would enhance antibody response to measles vaccine. And that in fact turned out to be the case. So this, and actually to study that, I went to Guinea-Bissau to the Danish Guinean collaboration, the BANDEM Health Project, because there was plenty of measles and plenty of measles vaccines being given. And that was just the right environment for me. I was so lucky that there was this place for me to study this hypothesis. And as a part of that, we showed that vitamin A enhanced measles antibody responses. We also intriguingly found that it was in a sex differential manner, so it particularly affected the boys. So that just ignited my interest in vitamin A, in vaccines, in the interactions between health interventions that normally weren't anticipated to interact with each other, and the sex differences in response to health interventions. So I thought I was going back to become a clinician, but well, I worked as a clinician, just did my internship, but I lost my heart in Guinea-Bissau and to research, and this was really why I went back, and I've been working there and studying these subjects ever since.
Outstanding, outstanding. And you know, Christine, when I watch your presentations and read a lot of your materials, when we get into the theme of these non-specific effects, you point out very a seminal work that was done or begun back in the late 1970s by Dr. Peter Abbey and his team, published in, I believe it was 1984, the paper Measles Vaccination and Reduction in Child Mortality, a community study from Guinea-Bissau. And this is, as you point out, one of the seminal studies that show, well, here, we're vaccinating a group against measles. We should be saving X many lives, but we're really saving Y, many more than could be accounted for by the deaths of measles alone. And this sort of was your entree into this whole area of non-specific effects. Could you just talk a little bit about this several year-long work that was done by this team and why it is so seminal into some of the topics we're going to be talking about a little later in the show?
Yeah, sure. So I wasn't part of this work. I only came to Guinea-Bissau in 1993. Mm-hmm. But back in 1978, the Danish anthropologist Peter Abbey came to Guinea-Bissau as a part of a Swedish mission. Guinea-Bissau had become independent from the Portuguese in 1974, and Sweden was among the first countries to acknowledge their independency. And they sent a mission to Guinea-Bissau, and they found out that child mortality was very astonishingly high in a quite crude manner, because they just simply went out to a district, counted all children who were 0, 1, 2, 3, 4, and 5 years old, and they observed that there were only half as many 5-year-olds as there were 0-year-olds. So they made that crude assessment that around 50% of all children died before they reached 5 years of age. And to look more into this very serious matter, they sent this mission to Guinea-Bissau. Peter Abbey was one of them, to find out why were children so malnourished, because everybody at that time thought that if there was such a high child mortality, it had to do with malnutrition. So Peter came as a part of a team and started doing anthropometric measures of all the kids in an area of the capital, the area of BANDEM, which later gave the name to the field station BANDEM Health Project, and quickly realized that children weren't malnourished. So they investigated 1,200 children, and only 2 were severely malnourished. So At the same time, they also observed that child mortality was extremely high. So here was kind of a paradox or something unexpected. Mortality was extremely high. It was close to these 50% that the Swedes had crudely estimated at the first mission. But there was literally no malnutrition, no severe malnutrition to explain this. So while they had just assessed all these children anthropometrically, a measles epidemic just hit the capital, and children literally died in the arms of Peter Arby of measles. There was a super high child mortality from measles. So every fourth of the children who got infected died from the infection. Obviously, a lot of children were already protected against measles and so on, but among those who were susceptible, those who got measles, a fourth of them died from measles. So, and what they could do, looking at the anthropometric data that they had collected, they could observe that there was absolutely no link between nutritional status. So the children had a large span of nutritional statuses. As I said, only a few were severely malnourished, but basically there was no link between the nutritional status and the risk of dying from measles. So this was another, paradox that everybody had thought that it was the malnourished children who would die from the infections, but it turned out that measles was quite unjudgmental in that sense. Measles didn't just kill the smallest children. Really, the interpretation at that time was so everybody was so sure that the infections killed the malnourished children, so it had been judged almost unnecessary to vaccinate against measles, because it was just assumed that if you save the malnourished children from measles, they would just die from something else. So with a measles vaccine, you might change their diagnosis, their course of death, but you wouldn't really change their destiny. Because the picture in the heads of the Europeans was that these malnourished children got an infection, and that was the kind of the straw that on the camel's back, that was what killed them. But it didn't really matter which infection it was. But the observation that measles infection did not only, there were no severely malnourished children, and there was no link between nutritional status and the risk of dying from measles, suggested that it would be really beneficial to give measles vaccine, because it wouldn't just save the children who died weren't just the children who were on the road to death. Measles also killed completely healthy children, so it was really worthwhile measles vaccinating. So after this pandemic, or this epidemic of measles was over, the teams, when they were doing their rounds, at that time they had drawn maps of the whole area, numbered all the houses, and numbered all the children, and given them a unique identifier. So they were going rounds, following up on the health of the children. And at one of these rounds, they gave measles vaccine. The assistants of the Benn Health Project gave measles vaccine to all the children who were at home. And the year later, when they came back, they were doing an assessment of what had happened in the meantime. So they gave measles vaccine to all the children who were at home. They didn't give measles vaccine to the children who were traveling or out of the house at the day. And there were days where there were no vaccines, the cold chain broke down, etc. So there was a comparison. It was possible to do a comparison of the health status of those who had received measles vaccine by our teams and those who hadn't. At that time, there was no other sources of measles vaccination in the area, and then look at the overall mortality. And what was really super surprising was that mortality was 70% lower in the vaccinated kids than in those who hadn't received measles vaccine for one reason or another. So this was much more than could be anticipated just on preventing measles infection. And measles is easy to diagnose, so it was also possible to determine that the unvaccinated children, it wasn't because they died from measles, that actually that just been this epidemic. There's a quite high level of immunity in the population at that time. So this looked like measles vaccine had protected children from dying from a number of causes, which were unrelated to measles infection. And that was, of course, so surprising. So actually, Peter Arby was fired from the Swedish mission. They stopped it because they thought this wasn't what we came for. We were going to look at malnutrition, and and here you come and tell us about these unbelievable effects of measles vaccine. But Peter was stubborn. Actually, the Danish broadcasting media made a movie about him at one stage called The Stubborn Man, because it has been kind of a trait that has gone throughout his career. He wasn't happy with just dismissing this surprising observation. So he went out to different places in the world where they had collected similar data, or where they had data on child mortality before and after the introduction of measles vaccine, and was able, together with the colleagues in the different countries, to make analysis from a total of 5 different countries which had this kind of data. And in all countries, it was the absolute similar, consistent observation of a dramatic decline in child mortality after the introduction of measles vaccine, which was not at all explained by prevention of measles infections. So this surprising observation was repeatable, and that eventually led to this seminal paper in 1984. So this took place in 1970, 1980. It took some time to analyze the data, become surprised by the results, repeat the observation, etc. But basically back, I think it was then in 1984, as you said, that Peter then published the first paper which described these stunning reductions in child mortality after measles vaccination.
Thank you for that overview. It's a fascinating story, as you say. It's quite seminal for this whole space, and now sort of moving from that, you were not involved in that, but moving into an area that you have been involved in and publishing quite a bit on, which we've actually discussed a little bit on the show, has to do now with tuberculosis and BCG vaccine. And here we have we celebrated the 100th year of this product being on the market, used for tuberculosis. It's an okay vaccine. It's been repurposed by certain members of the pharmaceutical industry for use in bladder cancer. But here comes research again. We think of BCG and tuberculosis, but you've been finding out that aside from where it should prevent or protect against tuberculosis, it's also doing other things in terms of preventing people from dying from sepsis, other pneumonias. You published on yellow fever, BCG vaccination protecting against experimental viral infections in humans, and we'll get into the some of the mechanisms to this a little later on. But please talk for a little bit about your own experiences with BCG, and wow, it's doing a lot more here than just tuberculosis prevention.
Yeah, so after the discovery that measles vaccine seemed to have what was coined non-specific effects, the effects that go beyond the specific effects against measles infection, we started looking into other vaccines and their non-specific effects. So at this time point, we have investigated a total of 10 of the routine vaccines, formerly and currently used routine vaccines, for their effects on overall health, to disentangle whether there were non-specific effects in addition to the well-known specific effects. And one of the vaccines, as you mentioned, we have studied is the BCG vaccine, which is only a semi-good vaccine against tuberculosis. It's not very effective, but it's the best we have. And it's recommended at birth in low-income countries, and used to be recommended up until the 1970s and 80s in most European countries, whereas in the US, actually, it was never recommended. There were 2 trials being done in UK and US in the 1950s, and the UK one showed protective effects against tuberculosis, and BCG vaccine was part of the UK program up until recently. But the US trial, as far as I remember, didn't show a strong protective effect against tuberculosis, and BCG was never introduced in the US as a routine vaccine. Anyhow, there were actually, as you said, it was invented 100 years ago by, it's called BCG for Basile Calmette Guérin, and Calmette and Guérin were the 2 inventors of the vaccine. And Calmette actually published in the early 1930s, shortly after the development of the vaccine, that they had observed in Paris that when they gave the tuberculosis vaccine to children at high risk of tuberculosis, they had a dramatic reduction in all-cause mortality. So at that time, children in Paris, they died, 25% of children in Paris died before reaching 5 years of age. So this was really, quite close to what you would see many decades later in low-income countries. But a surprise to me that these, well, it was high-risk children, but still they had such a high mortality. But Calmette observed that the mortality was only 4% in the children who received the BCG vaccine. So he actually wrote in his scientific paper in French that one could speculate that there was some extra benefit of receiving the BCG vaccine in addition to the protection against tuberculosis, because the effect on child mortality was so dramatic. But it's kind of sad to realize, but such observations may go unnoticed and may be forgotten again, just as it was when a Swedish doctor who introduced BCG vaccine in northern Sweden in the early 1930s also observed such striking reductions in particularly in neonatal mortality and in the first year of life, where tuberculosis wasn't expected to kill any children because it takes months to years for tuberculosis to develop. So really seeing that BCG vaccine reduced the mortality in the youngest children also made this Swedish doctor speculate that there were some added benefits of BCG vaccinating. But again, this insight was kind of lost on the way, and it wasn't until our group then started screening all the routine vaccines for their non-specific effects that this line of research was picked up again, and we conducted a systematic review of all the data sets we were able to put our hands on with respect to BCG. In the first place, we just looked at the observational data sets, comparing those who had gotten versus hadn't gotten BCG vaccine, and saw that BCG vaccine was associated with almost a 50% reduction in mortality, in child mortality, which could to some extent be explained by the fact that those who, children of mothers who get, well, children who get BCG at birth or shortly after are usually children whose mothers have some kind of health education, live close to the health facility, which would also mean closer access to treatment, etc. Whereas we know that parents are reluctant to vaccinate ill children all over the world. So, if you just compare vaccinated and unvaccinated children in a non-randomized fashion, there is some inherent, what we call healthy vaccinee bias. You will tend to find a very beneficial effect of a vaccine just because the children who are vaccinated are generally healthier than those who for some reason weren't vaccinated. So to get closer to whether what we observed, it was a very stunning effect on mortality. So we had the impression that this was not just about differences in socioeconomic, educational, etc. Status among the vaccinated and unvaccinated children. But of course, we wanted to get closer to whether this was a true effect of BCG vaccine. So we did two things. One thing was that we know that BCG vaccine leaves a scar on the arm of the vaccinated child in most cases, but for a few, it doesn't leave a scar. And that's usually when the vaccine is not applied correctly. So we took the group of BCG vaccinated children who all had at their vaccination card, it had been noted that they had received the vaccine, and then we divided them into those who had a scar and those who didn't have a scar. And we could kind of assume that those who had a scar had a correctly applied BCG, but those who didn't have a scar didn't truly have a BCG. It was on their vaccination card, but it hadn't been applied correctly. So among these children, there weren't the same healthy vaccinee biases because all of them had been brought for BCG vaccination. When we compared their mortality, we could see that mortality again was more than 40% lower among those who had a scar versus those who didn't have a scar. So this supported that BCG had some stunning effects on mortality, which weren't explained by the health-seeking behavior of the mothers. So the next step was to do a randomized controlled trial, and that can be really hard with a vaccine that's already approved, because if you want to randomize, you don't want to take away a vaccine, a recommended vaccine. that can really pose some ethical challenges.
Sure.
But we benefited from the fact that at that time, low birth weight children born with a birth weight of below 2,500 grams didn't receive BCG vaccine at birth because it was believed that their immune system might be too immature. So it was recommended in Guinea-Bissau and many other low-income countries to postpone the BCG vaccine until the children had gained more weight. And that would typically be around 6 weeks of age when they came for their first dose of diphtheria, tetanus, pertussis vaccine. So among these low birth weight children, we could actually ethically justify to do a randomized controlled trial, randomizing them 1-to-1 to either get BCG vaccine at birth or to get the usual delayed BCG vaccine. So basically moving forward the time of BCG vaccine for half of the children. And then we could compare in an unbiased fashion the mortality of children who received BCG at birth with those who only received it 6 weeks later. So when we looked at the neonatal mortality, the mortality in the first month of life, comparing these completely comparable children, we could look at their background factors. Our randomization was successful. They were similar children who only differed with respect to whether they had received BCG or no BCG at birth. Then we could see, and we have seen that in 3 independent randomized controlled trials now, that mortality was around 1/3 lower in those who had been randomized to BCG versus no BCG. And this wasn't because the children were protected from tuberculosis. As I said, it doesn't kill children in the first month of life. And we could show using verbal autopsies and hospital records that the children were dying less because they had less septicemia and they had less respiratory infections. So this really represented a non-specific benefit of BCG vaccine, which had nothing to do with its specific effects against tuberculosis, but had everything to do with what we might touch upon the mechanisms for, but that BCG strengthens the immune system of newborn babies and makes them more resilient, more resistant towards a broad range of pathogens.
And a perfect transition point, because as you were just mentioning mechanisms, you've published extensively on quite a bit that's going on here. You've talked about genome-wide epigenetic changes to monocytes. You have another paper that talks about the lipid metabolism, about how some of these vaccine-induced metabolites may serve as sort of adjuvants in certain ways, enhancing immunogenicity. You have another paper, a fascinating one on BCG inhibiting systemic inflammation, and this is such a hot topic now. So there's so much going on. There's so many different mechanisms here, which feeds this fascinating story of repurposing in general. I know sort of the core of a lot of this focuses on the innate immune response that we don't normally think of as having this memory and hanging around too long. But talk a little bit, just walk through sort of some of what you see in this mechanistic ecosystem via these non-specific effects.
Yeah, so as you said, historically, the innate immune system hasn't received a lot of attention. We are actually among the 5% of all living species that have an adaptive immune system, which we know develops this specific memory. Once more you have seen a pathogen, you will get your B cells, your T cells, your lymphocytes in the adaptive immune system to remember this pathogen so that you can respond quickly once you meet it, or when you meet it subsequently. And this adaptive immune system, particularly the antibodies, are so easy to measure. You can do that simply. It's been shown decades ago that they were once you vaccinated, you got these antibodies, and that was associated with protection against subsequent disease, etc. So I think that has been historically why the adaptive immune system has received and run away with all the attention, while nobody really paid attention to the innate immune system, which hasn't got this kind of specificity towards pathogens. And it was really basically believed that the innate immune system was a stupid first line of defense, which would buy your adaptive immune system some time to develop, but it wouldn't learn anything from the meeting with a pathogen that could be used in subsequent encounters. But actually, that was an oversight by medical doctors or by immunologists, on our sides in general, because insect people and insect researchers and plant researchers have known for decades that that insects and plants that don't have any adaptive immune system actually have an immunological memory. So if grain gets a fungal infection, it can actually increase its resistance and the subsequent plant's resistance towards that specific fungus and so on. So yeah, I cannot go into detail with this, I guess, but it's just to say that actually it has been acknowledged among other parts of research that the innate immune system is smart. Yep. But it just never occurred to anybody before. I think Mehaine Thea, a professor from the Netherlands, started looking into the innate immune system and its memory, and whether, well, basically demonstrated that the human innate immune system also has a memory, that the innate immune cells learn something from a pathogenic encounter that it can use in subsequent encounters. And he was interested in TLR4 receptors. It's a little bit technical, but just to say that there was a specific interest he had in how the innate immune system was activated, and he knew that, or he wanted some model for an infection and also one that stimulated TLR4, and he used BCG basically as a challenge. He didn't anticipate that BCG would have any other effects than stimulating the response to Mycobacterium tuberculosis, but he took out cells from from Dutch medical students who were BCG vaccinated as a part of going abroad. So he took blood samples before and I think it was 2 weeks and 3 months after they received BCG. And he wanted to see how their cells, their innate immune cells, responded when he challenged them with Mycobacterium tuberculosis to look into this TLR4 activation. And as a control exposure, he used Candida albicans, which is a fungus.
Yep.
And the results were so crazy when they came out because the BCG vaccinated Dutch students had also responded. They responded to Mycobacterium tuberculosis. Their innate immune cells recognized and responded to Mycobacterium tuberculosis, but they also responded strongly to Candida albicans. And the results were so surprising, so they thought it was an error. So Mihai, he just told me recently in a podcast that I'm doing called Vaccine Curious, I interviewed him about this, and he said, I wish we could say we were super clever, but it was really just an accident. But I guess what Mihai was clever about was not to just dismiss these results and throw them out as implausible. He actually got his student to go back, repeat all the experiments, and they came out again showing that BCG had trained the innate immune cells to respond more to Candida albicans. And then they tried other stimuli as well. They tried Staphylococcus aureus, all kind of different things that the cells shouldn't recognize after BCG vaccination. And they just saw repeatedly that BCG had enhanced the innate immune cells' capacity to respond to a broad range of pathogens. So this was, and by that stage, they realized that we had been doing epidemiological studies of BCG vaccine and finding these strong effects on mortality of BCG vaccine. So he wrote to us, and I remember sitting in a hotel bed in London, reading his email and just sensing that there was something extremely important going on right then, because we had seen these findings for so consistently of BCG saving children. We had published it, but we had also received the critique numerous times that this was biologically implausible. So there are editorials out there accompanying our papers where the authors say, well, yes, it looks promising, but it's absolutely biologically implausible that a vaccine against tuberculosis should reduce the mortality from septicemia and respiratory infections. So what Mehaine Thea had found was a mechanism which could explain so neatly why children, newborns in Africa could even we see these effects within days, much earlier than any adaptive immune system effect could possibly take place. It really all made sense in that moment that it was the innate immune training, which would have immediate effects in the babies that were saving them from dying from these other diseases.
That's really fascinating. And when when you were talking about sort of those 95% of other species that don't have that adaptive immune response, it's funny because we were just an episode we just did last week where we were talking about salamanders, and this, mainly they focus on their innate immune response, but there's been a lot of work done in amphibians that show how the innate immune response and all these interesting cytokines and so forth enhance some of these regenerative processes that we see in these lower organisms. And it just got me thinking, wounding is a very big part of that process. And when I think about sort of your BCG and scarring tissue issue there, I wonder, it's something maybe interesting.
Yes.
Regenerative component there. I was just wondering, separate from all of the infectious disease stuff, do you see any other very odd, not mechanisms I'm saying here, but any other really odd things like, wow, this shouldn't be happening. Clearly, okay, we're dealing with different infections here, but something divorced from infectious disease entirely. Anything you can mention on that front, or maybe it's too early in the research?
Well, no, I'm not quite sure what you're asking about, but I can say that BCG is not just about infectious diseases. So there's a huge interest right now in its effect, as you mentioned, on systemic inflammation, because we know systemic inflammation is key for a lot of diseases, and among others, diabetes, type 1 diabetes.
Yep.
Dennis Faustman from Howard is right now doing exciting stuff on BCG vaccine as a therapeutic vaccine to type 1 diabetes patients. There are studies that are now looking into the BCG's effect on bladder cancer, or rather looking at bladder cancer patients, those who receive BCG as a part of their treatment and those who didn't receive BCG, and look at their risk of developing Alzheimer.
Yep.
And there are some striking effects. I think we still need to see proper randomized studies. There could be other biases at play, but the effect that has been observed so far is so strong. It's like an 8-fold reduction in the risk of Alzheimer that it's hard to imagine that any bias can explain such a large effect. There are studies being done also on one study going back to, I think it was actually the US BCG trial that I talked about in the beginning, where participants have now grown old and they see lower risk of lung cancer in those who received BCG as part of the trial versus those who didn't receive, or received placebo or no BCG as part of the trial. So there are many potential applications of BCG. I think we're just seeing the top of the iceberg. It needs to be kept in mind, though, that with such a strong immune enhancer, there might also be downsides, and that, I think, a word of caution before everybody goes and get BCG vaccine is I still think we have work to do also with long-term follow-up of participants who receive BCG vaccine. It might be good to enhance your innate immune system at birth in a low-income country where you are hit by many infections, but we cannot exclude that there could be a downside later on in life, etc. One thing, as I started saying, we see sex differences. We also see them in response to BCG vaccine. So clearly, we are used to, when we look at specific effects of vaccines, they're context independent. So we know that women tend to make higher specific antibody responses than males, but basically we don't often look at different effect modifiers. We assume, and can reasonably assume for most vaccines, that they generate an immune response in most people who receive them, and they will be protected against the vaccine disease. But the interesting and complicated thing about non-specific effects of vaccines is that these are effects on the immune system and its ability to combat other infections. And clearly they are very context dependent. So they can be modified by sex, by age, by a number of other factors, such as other health interventions. So when I saw in the beginning of my studies that vitamin A enhance the specific antibody response to measles vaccine. It was in a sex differential manner. It enhanced it in boys. It didn't enhance it in girls. That was just the beginning of a lot of other work that I've done looking at whether vitamin A could enhance the non-specific effects, and actually showing that this was the case. So the non-specific effects of a measles vaccine is different depending on whether you receive vitamin A or not. And as such, the non-specific effects are, that's just one example of how context dependent they are. So we really need to do more work. But in the first place, I think what is happening now is the start of a paradigm shift in the understanding of vaccines. So going from seeing them as something that induces specific protection against the vaccine disease and nothing else, to really seeing them as these immune modulators as they are. And with that acknowledgement, it just opens the doors to a whole new research agenda where I think we will eventually be able to optimize the use of vaccines and optimize vaccination programs so that we have the complete, we benefit and optimize both the specific and the non-specific effects. And that might be different vaccines to the two sexes, different vaccines during the life course in order to keep your immune system strong and healthy and resilient.
Yeah, and I appreciate it, and thank you for bringing up the diabetes work. I had Denise Faustman on a show a couple of years ago, and I was headed in that direction. So thank you. Yeah, that's it's a beautiful example of some of the things that you're talking about, and how sort of we only beginning to scratch the surface of where we can go with this. But going down that path now, because you recently published in the Lancet this essay called "Vaccinology: Time to Change the Paradigm." As you were just saying, there's many directions that we could be going with this, and you outline several principles in this paper. If funding was unlimited, let's say, and if the sky opened up and whatever $100 billion ended up, and they say, okay, Christine, you're going to guide this program in these different directions. Obviously, you can look at different vaccines. You can look at combinations of these vaccines. We haven't even gotten into sort of the understanding of our existing microbiomes and the way we modulate those, what happens in terms of health and disease. Talk a little bit, you can talk a little bit about sort of some of the principles that you mentioned in this paper, but sort of, if funding was no object, how would you, what kind of system would you design for the future exploration? Because, I mean, this is a whole separate industry in a way than pharma and just the vaccine business as it stands today. Where would you go with some of this, please?
Oh, yeah. What we are, as I said, we are in a situation of a paradigm shift in the sense that we have seen so many observations now that contradict the current paradigm for vaccines. I think there is no, it's more or less generally acknowledged among researchers. We still have the policy people to deal with because they find this terribly challenging, and it is, of course. But among researchers, I think it's generally acknowledged that we now have so many observations from epidemiological and immunological studies which contradict the current paradigm that vaccines only have specific effects. So as you said, we are in the process of now outlining and understanding the principles in the new paradigm of vaccines. And there we have a total of 6 principles, which are in the Lancet infectious disease paper that you mentioned, which we find we have repeated observations that we have repeated so many times that we now feel confident that they are a part of the new paradigm. And these 6 principles are about the live vaccines, the live attenuated vaccines, where we see for all the live attenuated vaccines we have studied these beneficial non-specific effects. They simply reduce overall mortality much more than explained by prevention of the vaccine disease. A very challenging observation is that for the non-live vaccines, which contain the dead pathogen or parts or products of the pathogen, we don't see the same training. In fact, we do see that for girls, coming back to the sex differences, it's very consistent for girls. For 6 non-live vaccines, girls who receive these vaccines, they are protected against the vaccine diseases, but they get more ill and they die more from other infections. This is obviously very concerning. It's seen in low-income countries with a high mortality rate, but it's so non-trivial that actually an Australian professor calculated recently that if we could get rid of these negative non-specific effects, we could probably save 1 million children every year, just by simple changes of the vaccination program. Because, here comes another principle. What we have seen is that the most recently received vaccine is the one that primes your innate immune system and your general resilience towards other infections. So basically what this Australian professor did was making the calculation that based on the existing knowledge, if we change the current vaccination program from having, as it is now, most non-live vaccines, most of the time during the first 5 years in low-income countries, you have non-live vaccines as your most recent vaccine. If that was changed, the sequence and combination of vaccines was changed into having live vaccines as the most recent vaccine, then one could save these 1 million child lives per year globally. Other principles are about maternal priming, which seems to be very important. So what your mother has experienced primes your own immune system. So the live vaccines generally seem to be better and have stronger non-specific effects if they're given to children of mothers who were vaccinated themselves, or if they're given in repeated doses. And a last principle is that vaccines interact with each other and with other immunomodulatory health interventions, as I also mentioned. So these 6 principles, my dream would be to have enough funding to just go out and test these principles and their deductions in multinational, multi-center randomized trials. There are so many promising ways to alter the vaccination programs, not stopping giving any vaccines, but rather, as I mentioned, changing the sequence and combination to optimize the program's impact on overall mortality. This obviously would take lots and lots of funding. We're talking at least 5 numbered amounts of US dollars to 6 numbered. Anyway, I can't translate from Danish crowns to US dollars immediately. It would be a huge number of money of dollars. A lot of money to actually conduct such trials, and it would take a concerted effort from many partners from many countries. But the promise, as I said, of 1 million child lives saved on a yearly basis should be incentive to do these studies. So we really hope to be able to convince people that this is necessary and important. I'm an epidemiologist, so I would obviously go in that direction, but I would work together with immunologists who should be drawing samples from those participating in the randomized trials for immunological analysis of what kind of changes we could identify in the blood of those participating in the trials, possibly also in the feces. You alluded to the microbiome, to the nasal microbiome, etc., to try to understand better the immunological mechanisms, and also importantly to identify markers of a strong immune system, which is still the missing link we are having. We measure all kind of cytokines, etc. There's still a lack of studies directly linking these immunological readouts to overall survival. But with this kind of studies, we could make some rapid progress. And again, the incentive would really be to be able to, in the first place, and this is what has been driving me since the beginning, to make an impact on child mortality in low-income countries where many children still die. I mean, mortality, I started out by telling you it was 50% in 1978 in Guinea-Bissau. It's down to 8% now. But it's still far too high. So this is, I think, my biggest challenge. This is what I really want to change. But on the other hand, I think we shouldn't ignore that the potential in these observations for improving health also in privileged high-income countries is there, both in childhood, maybe better controlling childhood infections, which are also prevalent, if not lethal, in high-income settings, but also in terms of how we can potentially modify our immune systems throughout the life course. One thing we're really interested in right now and also studying is whether we can, with the BCG vaccine, with measles vaccine, improve the immune system of elderly who are known to have immunosenescence, a dampening of their immune system by the end of their lives, and that causes a lot of infections and is a big burden on these people and on society. So if with BCG vaccine we could actually enhance their innate immune systems and make them more resistant towards infections, that would be super important and interesting. The non-live vaccines I alluded to, they actually seem to, in our studies, to dampen the innate immune system. So they induce tolerance towards other pathogens, which could go a long way to explain why we see that they may enhance mortality from other infections in low-income settings with a high infectious disease pressure. But if it's really true that they can downregulate the innate immune system, well, then there are diseases also where that could turn out to be actually important, that you could dampen your innate immune system. So my incentive is the 1 million child lives in low-income countries, but I think there's a huge potential also for improving health all over the world and in at all ages, and even perhaps in veterinary use. So yes, that was a long elevator pitch, I guess, of what I would do if I had unlimited funding.
Oh, that's awesome. And I think, I think the time is right in the sense that repurposing is become extremely hot in recent years. And you're talking about repurposing really an entire segment of healthcare. And then what you've just described, I mean, you're focusing basically on everything from the beginning of life to all the chronic degenerative disease potential throughout our life to, as you were just saying, with immunosenescence and, not just the ability of our immune systems as we get older to hunt down these microbes, but also, the connection to cancer and other things where we need our immune system to constantly have that surveillance capability. It's very exciting. It's such a diverse, untapped domain. And I'm just really, as I said, I was fascinated when I read, and I apologize we didn't go into it, and please, if you want to say a couple words about the recent COVID work, that's fine. If not, but when I first heard about, you've been very popular in the news the last couple of weeks with the COVID study, but there's a lot more to everything you've been doing. So really, really exciting. Do you want to say a few things about the COVID study, or if that's,
Yeah, well, I can say that for us, obviously, with decades of work looking into the overall health effects of vaccines and seeing for all the vaccines that we have studied that they have these non-specific effects, it was obvious that we were right from the beginning asking ourselves and others whether these new types of vaccines would have non-specific effects and whether they would be beneficial or potentially harmful. We have two new types of vaccines, the mRNA vaccines and the adenovirus vectored vaccines. And my first impression or thoughts were that they might resemble live vaccines in the way they act on the immune system. So I was actually hoping that they might turn out to have beneficial non-specific effects, just as we've seen for live attenuated vaccines. To get closer to that, one thing I should mention is that the current system for testing vaccines is not set up to measure non-specific effects.
Right.
So it basically measures the effect on the target disease, the target infection, and then there's a collection of data within the first weeks of administration on the well-known adverse events like fatigue, fever, soreness, and redness on the injection site, etc. And then the studies collect severe adverse events, so they collect data on hospitalizations and mortality, but there's no capturing of other infections. Right. So if you have a pneumonia or a bronchitis or an otitis or some other infection as part of a randomized controlled trial leading to approval, that wouldn't be registered as part of the trial. Unfortunately, because for all we know, the the presence or even the absence of a pneumonia that you would not otherwise have gotten, that could all be indications of non-specific effects of the vaccine. But these trials are not capturing the information, but what they do capture, as I said, is hospitalizations and mortality. So we looked at the phase 3 trials and took all of these reports of the phase 3 trials of the mRNA and the adenovirus vector vaccines and to the longest possible follow-up before the trials were unblinded and controls were vaccinated. And this was just a few months, because as you know, after the emergency approval, all the trials started vaccinating. They offered vaccination to the control group. So we only have a few months of follow-up time in the randomized controlled trials of the mRNA and the adenovirus vector vaccines. But we teased out from the supplementary material the deaths that occurred in the vaccinated versus the unvaccinated during the blinded phase of the trials. And then we saw another surprising thing, because when you look at all-cause mortality, there's no effect of the vaccines in the mRNA among the mRNA vaccinated. So there's an effect on COVID mortality, as would be anticipated, but that's actually offset by a slightly higher mortality against other causes of death. So the net result is that there's no overall effect of the mRNA vaccines on overall mortality. Numbers are so small, so it comes with a broad confidence interval.
Sure.
And in that sense, we cannot exclude either quite important mortality reductions or quite important mortality increases. But the estimate is really a 1. It's like there's no difference in mortality among the vaccinated and the unvaccinated. In the group vaccinated with, or in the studies, in the trials that used adenovirus vector vaccines, we saw that there was lower mortality, significantly lower mortality from COVID-19, but there was also significantly lower all-cause mortality and significantly lower mortality from non-accident, non-COVID mortality causes, these causes that we assume that we could target with non-specific effects. Mm-hmm. So basically, when we compared, the trials didn't compare, as you know, back-to-back mRNA versus adenovirus vector vaccines. But if we compared the estimates of effect of the mRNA vaccines obtained in one set of trials with the estimates of effect of the adenovirus vector vaccines obtained in another set of trials, these two effects were completely statistically different. So the adenovirus vector vaccines seem to have beneficial non-specific effects, reducing not only COVID, but also other causes of mortality, but the mRNA vaccines didn't have these effects. So this is, as I said, numbers are small, and unfortunately, they aren't likely to get much bigger because there aren't more trials going on. Right. But to us, they suggest that there are important differences in the non-specific effects of these two categories of vaccines. And what we propose is that there are studies done now randomizing people, and so comparing head-to-head mRNA versus adenovirus vector vaccines, where in settings where that might be possible. So I don't think we would ever get permission to do placebo-controlled trials, but at least I think it would, to get closer to the issue of non-specific effects, studies randomizing to either or of the two vaccines would be very important.
Yeah, and it's, it's especially where we are today, putting COVID aside, but, we've done a lot of shows on sort of biosecurity and sort of spillover and what's coming next. And, we have these new tools, and we really, as you were saying, we really need to know, beyond whatever X, Y, and Z is coming down the road, what else these products are potentially doing overall for health. So you're definitely in the right spot. And really, as I said, the intersection of these domains, and it's going to be a fascinating future as we continue to study and you continue to do this work, and just really wishing you the best with all of it. It's been a fascinating story that you've outlined to us. For everybody that is going to be listening to this particular episode across the various podcast networks or watching on the YouTube channel, again, you've been listening to Professor Dr. Christine Stabell Benn, Professor Global Health, University of Southern Denmark, doing really amazing things at the intersection of vaccines, non-specific vaccine effects, repurposing. Christine, I want to thank you for taking the time out of your evening to come talk to us for a little while about all these exciting themes. I want to thank you for obviously all the work you're doing. And as we say on our show, thanks for helping to create a better tomorrow for so many people via the work you've been doing and you continue to do. It's really a really fascinating story.
Thank you for inviting me again, and thank you for good questions. You really read up on all we've been doing. I'm impressed, and it was a pleasure talking with you.
It was great seeing you. Thanks so much.